Thank you for asking me to present a challenging case. I hope I would make it a little challenging. And at the outset, I would like to thank Dr. Shahana Mazumdar from Delhi, who sent this case for an opinion to me. Now, this was a 17-year-old boy who came to us in August 2012 with history of sudden onset, painless, rapidly progressive loss of vision in both eyes of 2 weeks duration. He lost vision in the left eye first and followed by the right eye 5 days later. He gave history of low-grade fever with sore throat, which lasted for a couple of days, about a month before the visual loss. And there's no history of any other systemic illness or trauma. So when he presented, now you can see it here, he has visual acuity of counting finger. His intraocular pressure is 18 millimeter. There are no signs of inflammation. And what you see here in the macula posterior pole is grayish-white areas with a lot of hemorrhages that one can see. And the picture in the left eye was a little nastier, but almost identical. And here again, the visual acuity is just counting finger, and pressure is 17 millimeter, and there's no signs of intraocular inflammation by way of any vitreous cells or anterior chamber flare of cells. So, anybody would like to take a guess at this point of time? What are we dealing with? Move on. And this is the infrared pictures we are trying to see if there is anything at the level of the choroid. And I'm sure you can all make out there was nothing contributed by the infrared reflected images. So was the fundus autofluorescence images, where you might see a little bit of, I think we could see better if they could split up these lines, but we could see a little bit of hyper autofluorescence. But you could certainly see in the left here some hypoautofluorescence because of the presence of blood in the retina. We thought we'll do a fundus fluorescence angiography to see if we could get any clue as to what was happening. And unfortunately, we did not get any clue except for a little bit of transmission defects. You can see in the center some kind of hyperautofluorescence surrounded by little black hypoautofluorescence. Really, we don't see much. And so is in the left eye. Even the late frames, we really don't see much. Now, this was the most interesting image when we did the post-CT. Now, any guesses at this point of time? This is the OCT, a vertical scan passing through the center of the fovea. What you see here is the internal limiting membrane, and you see here down the okay. And what you see here is increased reflectance from the choroid because of there's no light being blocked by the retinal tissue, so there's increased hyperreflectivity from the choroid. Now this is on serous CT. You can see the highlighted green line is the raster line, which is taking this image here, and you can see somewhat similar to what I showed you on the spectralis. And this is somewhat similar phenomena happening. This is the right eye. This is the left eye. A similar phenomena happening in the left eye. So this guy has 17 years old boy, bilateral, practically symmetrical, a little delay of 5 days between the onset of the two eyes, and he comes to us with no signs of inflammation. And there is a preceding history of fever for a couple of days. So this is what it shows here: the internal limiting membrane and the Brooks membrane, and nothing in between in the macula. So what was the treatment history? She was, as I said, he was seen by Dr. Shahana. I don't see her in the audience here.
Yeah.
She is here. So Shahana, thank you so much for setting up this challenge. And she helped us in resolving it also. I must acknowledge that. So following investigations were done in Delhi. Anybody who do those, like Amod's reaction was negative. Serum ACE levels were reasonably okay. There was minor rise. HIV was non-reactive. VDRL was non-reactive. Toxo IgG was positive. Any one of you would think these are toxoplasma issues. Anybody voting for it? So for good reason, because toxoplasma is the retinitis lesion, a necrotizing retinitis doesn't involve the entire thickness of the retina, and in fact it goes into the choroid, so we call it retinochoroiditis. The patient was given intravenous acyclovir and later switched to gemcitabine along with azathioprine. This is 3 days later. We wanted to see what was happening, so we took this patient in, and we were desperately looking for clues. And we repeated the angiogram, and again the angiogram was not really revealing the diagnosis. Many a times, we believe in some kind of magical solution coming from some of the lab or some of these investigations that we routinely do. Here it was helpless, except that it showed that there was a lot of blood here which had accumulated with a little bit of level there, you can see. So this is the blood which is getting accumulated in the empty space in the retina. So we again did what many of you would do, like do a tap, like Dr. Kalpana was lucky to get that CMV positive. I'm sure we would get it negative here, both for herpes groups. The MRI brain, we thought, well, our top on card was, perhaps it was some kind of a necrotizing retinitis caused by herpes viruses, and we were looking for herpetic encephalopathy or encephalitis, which was not revealing. We sought an internist consultation, and there was no systemic findings. So we stopped Azoran, the belief that if it were viral, because I was really concerned about this boy, something happening which is necrotic, and if it was happening in the brain, it would kill him very soon. And so we shifted to valacyclovir and a simpler treatment, less expensive perhaps, but without knowing what we were doing. With this, within 2 weeks, the visual acuity started improving. You can see a little bit of improvement here in the left eye. Again, the hemorrhages are going away, and you can see here the picture here of the spectralis was we scanned. Probably the fluid is decreasing, and when we compared the one on the top is at presentation, and the one on the bottom is a couple of weeks, 3 weeks later, there is little decrease in the cavity which has been created. And this is the left eye, as you can see the spectralis, and this is where you can see the left eye, which was the first affected about 5 days before the right eye got affected. Here what you can appreciate is that the whole thing seems to be collapsing and kind of coming down. We ordered the multifocal ERB, which was led by Dr. Rima Bansal, and she believes that this shows, as you can see here, all the rings are showing the amplitude which is far below the normal activity. So this is actually not adding any value. Sorry, Rima, but this is not a reflection on you, but the multifocal ERG, because we were seeing there was no retina in the macular area, so we expected this to be happening, and this is what is in the left eye. Similar findings on multifocal ERG. Now this is at about 4 months now. Can anybody tell me what's happening here? The lesions have healed. And the lesions have healed beautifully well, as you can see here. There's a lot of galactic activity, and if you can appreciate these ray-like projections, these are, all around. Okay, and this is very little fluid left in the right eye. This is the later affected eye, and the left eye actually has no fluid. And the visual acuity actually has improved at this point of time. I'll just show you. And this is at about 9 months. And this is what even the right eye is now good. This is the 9 months, the left eye, well scarred. And this is 624 at the last follow-up that patient had with us. 624 in the right eye. And this is the OCT images. 624. Now, anybody would like to, having seen, personally I had never seen the most spectacular OCT images. If any one of you have seen this kind, would have the diagnosis right there.
Is he still on well? Was he still on well?
He was on well cyclovir, yeah. We gradually tapered it to VD and then 1 gram OD. He was getting all right, after 4 months, the lesions, there was no intraretinal cystic spaces and it had all become atrophic. Well, at this point of time, the parents complained, this guy is not behaving well. Okay, so we sent him to psychiatric department for evaluation. I'm going to show there. This is the video courtesy the father of the patient. The patient had some abnormal movements, and the parents complained that this fellow doesn't remember anything. And they consulted a physician, and something which had posed a major challenge to us, ophthalmologists. They said, 17-year-old boy with this picture, okay, is no big deal, in diagnosing. This is the EEG that was ordered and shows this abnormal activity, which is given a very, very classic name regarding that. But this is to show that he had spurts of this abnormal electrical charge, which was responsible for the complaints. He had myoclonic seizures, okay, and developed dementia over the next 2 months. And in retrospect, when we asked him, there is history of measles at the age of when the child was 18 months old. This got done in Delhi, the IgG for measles virus was more than 1 in 250, and so was in the CSF. Now anyone would, except Shahana, anybody would like to... SSP. So what gave you the clue? And this we are dealing with SSP.
History of measles?
History of measles. Somebody said it louder, please.
Myoclonic.
Myoclonic seizures. Yeah. This is myoclonic. Okay. So how many of us have ever asked our patients with uveitis present, do you have? I'm presenting this case actually out of guilt because I didn't know the diagnosis until very late. So this was a case of subacute sclerosing panencephalitis, and diagnosis of SSPE is often missed due to very low index of suspicion. Unless you have high index of suspicion, you will not be able to diagnose these cases of SSPE. Now, what is SSPE? It's a progressive neurologic disease which is caused by defective, some kind of polymorphism in protein M of the measles virus, and typically follows a preceding measles, usually before the age of 2 years. And this becomes a challenge in developing countries where they do not have the measles vaccination problem. all those countries, Western countries, where they have a measles vaccination program, they have reported stray case because of the vaccination, but none that occurs following the, and they have actually very poor index of suspicion for these kind of patients. And giveaway is, as you said rightly, is myoclonic seizures or drugs. By that time, it's too late. Okay. So more often in men and personality behavior, personality changes and behavioral changes. And we did send this patient to psychiatry because the parents said he's behaving very oddly. We thought of sending to psychiatry, it didn't occur to them. Okay. And visual symptoms are seen in nearly 50% before, and this is the stage when they have the visual symptoms. If you don't pick it up, there's no cure for this disease. If you pick them up at this stage, when they have the visual complaints of uveitis, perhaps you could. Now they heal so typically. This is the focal retinitis lesion with the gray ragged area, hemorrhagic, and they heal very quickly actually. And we saw the difference of 5 days between the two eyes, and one eye which was having the earlier attack was healing, and they call it a spongiform. In the brain, they have the similar pathology which they develop, sponge-like, necrosis of the brain tissue. And something similar was happening in the retina. The neural tissue was just kind of evaporated there and left behind some bridges. It heals with gliotic scarring and these radiating lines. Okay, now we know that this, if I see the next patient, I will not make a mistake, but this was a very, very challenging to diagnose. There is no minimal or no inflammation of the choroid or the vitreous, and histopathology is very, very characteristic. People have shown presence of viral measles particles and high levels of measles antibodies. This is what I regret the most, that we missed doing it. It was done by a physician in Delhi. The antibodies in the serum and CSF typically have very high levels. The T2 weighted MRI images may show some changes, but unless you know what you're looking for, you would perhaps miss. And in this patient, even knowing the diagnosis of SSPE, the neurologist did not pick up the MRI changes. So probably they are not very as strong an evidence as the CSF levels and serum levels of IgG. Now people have tried to treat them, and the consensus appears to be emerging that if you treat them before they have a neurological disease with alpha interferon or beta interferon and some of these isopronosine and these, you could delay or prevent the occurrence of fatal disease. The disease shows a relentless progression. Only 5% show a spontaneous remission, and 95% would die within 5 years. In fact, this boy is now entered into almost like the fourth stage of quadriparesis and total dementia, and no control on bladder and bowel. So we could only discuss with his father, whom I saw 2 days ago. But